So the real thing that I want to talk about today is knee replacements and some new technology we have here at Charlton, and kind of tell you how we've been, advancing orthopedic care here at Charlton. So the knee is actually interesting. People think that it's just a simple hinge joint, but there's a lot more motion in it during flexion and extension of your knee. But in all reality, there's two bones. There's your femur and your tibia, your shin bone, and then your kneecap that articulates with your femur as you flex your knee. When we look at causes of knee pain, it's very similar to kind of the hip arthritis, where it can be the arthritis like we talk about, that's the general wear and tear of the joint, but people can have issues with tendonitis, they can have issues with instability, they can have meniscus tears in there, or even nerve compression up in your spine can cause you to have knee pain. Similarly, when we look at x-rays, just like in the hip, there should be big spaces between the knee joint, both on the inside and then on the outside part of your knee. This person, you can see they have severe bone-on-bone arthritis on the outside part of their knee right here, and that's what causes the swelling and the pain. I think knee arthritis is interesting from a public health perspective. It's 32 million adults in the United States have it, and if you're older than the age of 45, 1 in 5 people in this room have knee arthritis by the age of 45. I think it's really interesting because it's the third most rapidly rising condition that's associated with chronic disability behind dementia and diabetes. So if you were talking about something that significantly impacts our population here in Dallas, knee arthritis is really a big deal. And I think also the stats are pretty telling, and that it reduces your physical activity, and it causes basically a 50% increase in your all-cause mortality rate. So you're 50% more likely to have kind of severe health problems if you have knee arthritis. So this is something that we take seriously because we want you to be active. We want you to be pain-free while you do that so that you can live your life. So kind of treating people's knee arthritis is a big passion of mine. When we look at non-surgical treatment options, very similar to how it was with hip arthritis, where we do anti-inflammatory medications. We can do weight loss, which is big, and then the big one that's a little bit different is injections. Actually work pretty well for knee arthritis for a while. The knee has a very thick, what's called a capsule around it, which you can think about a balloon that surrounds the knee. We can put medicine inside there, and it stays and works in your knee to decrease the inflammation and swelling for close to 3 months. People can have steroid injections into their knees for as long as they work, every 3 months. The other option that we have is something called hyaluronic acid gel injections. Imagine something that's the consistency of honey. It's like a lubricant for the joint surface, and that can be helpful as well for certain people. We have some newer non-surgical treatment options that I like as well, that we work with our radiology colleagues here at Charlton. So there's two options, and the first one is called the genicular artery embolization. Basically, there's small arteries that supply either the nerves or the synovial tissue, which is basically the lining inside of your knee joint, with blood supply. And that's where we get a proliferation of this tissue. And you can see here, all this contrast dye comes down through the artery and into the knee joint here, where there's lots of blood vessels in there. All of those blood vessels are what pick up on the pain fibers. So now we're able to go in and we can embolize, or basically block off those arteries and decrease sensation to the inside part of your knee. It's a good surgical treatment option for people that either don't want to have knee replacement, or that physically can't from a comorbidity perspective because they have uncontrolled diabetes, or they weigh too much, or they just physically, their heart wouldn't survive having a large operation. This is a temporary thing, but it's a little bit more long lasting than some of the injections that we do. And I find that patients have pretty good relief with it. The other option that we have out there from our radiology colleagues is what's called a genicular nerve ablation. Very similar in that the knee has multiple nerves that supply sensation to the knee, called the genicular nerves, and they can go in and they can deaden these nerves and reduce the sensation to the pain fibers within your knee joint. Again, it's a temporary thing, but I think it's a good procedure to try with patients that are trying to avoid knee replacement for as long as they can. Ultimately, though, most of the time when we talk with people about their knee arthritis, the people that do well with knee replacement are the ones that have pain on a daily basis that affects their quality of life. that have tried and failed injections, that have bad arthritis on x-ray. If you have all 5 of those, I know that you're on this pathway to knee replacement, but I let patients tell me when they want to have the surgery done. So at some point, people will show up in office and they'll say, I'm tired of having injections. This isn't working anymore. Now it's time I think I get my knee replaced. I joke with people that I do enough surgery. I don't need to convince you to have it. You're going to tell me when you want to have it done. There's a couple different options for knee replacements. There's one called a partial knee replacement where we replace just 1/2 of the knee. So you can see the inside part of this knee is replaced, but the outside part is not. Or a full knee replacement. Pretty common question that I get is who needs a full knee replacement and who needs a partial knee replacement? I think it, depending on who you talk to, these are pretty hot topics within orthopedics, to be honest. If you have arthritis on both sides of your knee, inside and out, you need a full knee replacement. If you only have arthritis on half of your knee, then a partial knee may be okay for you, but there's a lot of criteria on who does well with partial knee replacements. Partial knee replacements have a roughly 10% failure rate over 10 years. And the main reason that they fail is that people get arthritis in the rest of their knee and they need to have it revised to a full knee replacement. So usually if somebody is older than the age of 65 or so, I think it's worth just doing the full knee replacement so that you know that you don't have to have surgery again. Similar kind of preoperative stuff compared to the hip replacements. So we still get pre-op clearance. The surgery itself takes roughly an hour to an hour and a half for the entire procedure. The big thing here too, just like the hip replacements, is in the past, if you have friends that had their knees replaced 10 years ago, they probably tell you, oh, well, I spent 2 nights in the hospital, or I spent 3 nights in the hospital, or I had to go to rehab. The data is pretty clear at this point, and I would say that I try and do almost all of these as an outpatient if possible. There's no difference in complications, readmissions, or any kind of other things. It's a lower cost, and patients are generally more satisfied. I don't think anybody could stand up and honestly tell me that the hospital beds are more comfortable than their bed at home and that the food is better here than it is at home, but we can talk about it later if you want. When we think about recovery, you're immediately walking, putting full weight on your leg, using a walker after surgery. I have therapy come out to your house for the first 2 weeks, and then you transition to go into outpatient physical therapy. Recovery is a little bit harder. The first 2 weeks are terrible. I tell everybody, you're going to hate me. That's okay. I'm used to it. I'll get over it. It's not a big deal. But usually by that 3-month mark, people are roughly 95% recovered, and they're doing well and happy they had their knee replaced, but still a full 1-year recovery, just like hip replacement. No restrictions after surgery. So hiking, skiing, biking, whatever you want to do, I encourage you to do it. The reason we do knee replacement is so that you can live an active, pain-free life, okay? Then we can talk about some of the advances in knee replacement technology, and I think this is kind of the interesting part of the talk. Is in the past, knee replacements had to be cemented in, and the best way to think about cement is it's like grout. So we would put this cement into your bone that would interdigitate with the bone, between the bone and the prosthesis, but there was always a chance that it would become loose later on in life, 10 or 15 years down the road. At this point now, we have newer technology where we can actually design these implants that have rough surfaces on the bottom that are the exact, that have pores in it that bone like to grow into, and now bones grow into the prosthesis, so there's no risk of having loosening later on in life. A newer thing that's out there is something called smart implants. So you can see that on the bottom of this here, there's this little yellow peg on this tibia component here. It actually can transmit via Wi-Fi to a hub and then to me, and it lets me know how many steps you take a day, what your knee range of motion is. It actually can alert me if you stop taking steps, because then I can call you and I can ask you, what's been going on? Why haven't you been moving this week? I find that most people don't want their knee replacement monitoring them, so I don't push this. But if you really want this, there are options out there.